عبد العزيز ازيك معاك ايه؟ ممكن تشوف كده بس الصوت واضح صوري واضح. عملت انا خلاص. نشوف بس الصوت كده مظبوط. لا خلاص مش هلخبط حاجه. خلاص مش هلخبط. المهم حاجه دلوقتي واضح.
Okay. Good evening, everybody, dear friends. We have a year past now. Our society is only 6 months young. Its vision is to have a media for exchange of knowledge, experience, and allow interaction of all shoulder surgeons around the world. Our mission is to present shoulder surgery knowledge to young doctors and encourage innovation to improve shoulder treatment. This integrity and loyalty to the cause was felt by our colleagues in Egypt and around the world. We had 4 high-quality international webinars, all accredited by the American Association of Medical Education. It was visited by 3,907 shoulder surgery doctors and physiotherapists from 99 countries around the world. Thanks for all our followers and attendees. We are more enthusiastic and stimulated to make this better and better. Thank you very much. And I invite my friend Dr. Yasser to start the moderation of the 5th webinar on dislocation, please.
Thank you very much, Dr. Bassem. It's my pleasure to introduce the guest speakers. We have Dr. Hani Sayed from Saudi Arabia, Dr. Oliver Verbach from Belgium, Dr. Mohammed Assasi, Cairo, Egypt, Dr. Ahmed Andil, Alexandria, Egypt, Dr. Bassem Farega, Cairo, Egypt, and Dr. Kovacs from Germany. The title of the webinar will be Arthroscopic Inferior Capsular Shift Surgery versus Suture Anchor Fixation for Recurrent Anterior Shoulder Dislocation. We'll begin the first presentation. It will be by Dr. Hani Sayed. It will be on the evolution of the operative treatment of anterior recurrent shoulder dislocation. Please, Dr. Hani.
Okay, good evening. Good evening, everyone. My voice was clear?
Yes, sir, clear.
Yes, your voice is clear. Go ahead.
Okay. So my topic today is about evolution of operative treatment of anterior shoulder dislocation. Outline of my topic, I will talk about the natural history of anterior shoulder dislocation, the evidence base for surgical stabilization, and after that we will take a journey on the history of surgical and arthroscopic stabilization. So the natural history. What happens if we don't fix our anterior shoulder dislocation? The recurrence is most common, and the age is strong correlation, as Rowe mentioned on 1980, as a rate of recurrence below 10 years old is about 100%. From 10 to 20 years old, it's 94%. From 20 to 30 years old, it's 79%, and male more than female. From the literature, Hovels on 1987, the age as a risk group below 22 years old, more than 55 recurrence. From 20 to 30, it's more than 37 recurrence. From 30 to 40, it's more than 12% of recurrence. Walton in 2002, he used 2 age big groups, below 20 and over 60. Below 20, it's more than 70% recurrent. More than 60 is 65% recurrence. So what is in the literature's data support surgical stabilization of anterior shoulder dislocation? Curly et al. In 1999, prospective randomized controlled trial with 2 years follow-up, more than 47 recurrence with conservative management. On the next 16% was primary stabilization. Otten et al. In 2002, 75% recurrence with conservative treatment and 11 with surgical stabilization. Curling et al. In 2002, 166 patient with 3.5 years follow-up, 61% recurrence rate with the age group from 20 to 30. So he's recommend surgery for the age group from 20 to 30 as a high risk. Jacobson et al. In 2007, level 1 evidence-based prospective randomized controlled trial below 40 years old, 54 recurrence rate with conservative management, even the non-recurrence with 74 unsatisfactory result with 10 years follow-up. On the next hand, 3% recurrence with open surgical repair, and with 72 got to excellent result and 10-year follow-up. So we'll start the journey on the history of shoulder stabilization, of the anterior shoulder dislocation. We found that Hippocrates, 400 years BC, is the first one described surgery for anterior shoulder dislocation. He described use of red hot iron, make burning to the soft tissue, formulation of the scar on the anterior shoulders to prevent external rotation. So it's the first idea to treatment of the anterior shoulder dislocation. The history is a big 2 items, open and arthroscopic. Open soft tissue, open Bankert, near capsular shaft, Petit Blau, Magnuson stack, modified technique of Magnuson by Rukud, Connelly operation, bone, Presto, Latorge, iliac crest graft, osteotomy, Weber and Meyer. Arthroscopic procedures start from stable transverse sutures, bioabsorbable tacks, suture anchor, arthroscopic capsular plication, thermal capsulography, arthroscopic Bankert, and arthroscopic massage. We will start with soft tissue procedures. Bankert on 1923, he is the first one describes Bankert lesion, which is a avulsion of anterior labral complex from the anterior glenoid. And before Bankert, there was French terminology by Porca in 1890, and after that, Persis in Germany at 1906. Open Bankert, he described transverse incision or L-shaped incision as the subscapularis at the junction between upper 2/3 and lower 1/3. And use 2 or 3 drill and start to plication the tissue and the subscapularis with the arm on 45 degree of abduction and 45 degree of external rotation. And a lot of modification come after that on this technique. And he published his technique on British Journal of Surgery at July at 1938. He describes the pathology and the treatment of recurrent dislocation of the shoulder joint. Magnuson at 1943, he describes the transfers the subscapularis from the lesser tuberosity to the greater tuberosity. So he make enforcement of the anterior inferior part of the joint with sling for the glenohumeral joint with recurrence from 2% to 17%. Galli at 1984, he described technique using tensor fasciolata from posterior approach. He passed it from posterior to anterior through the drill on the scapula. And after that, he drills the coracoid and the humeral head. So you have a very potential complication of drilling tunnel. So it's obsolete. Petit Blau on 1984, he describes attractive and alternative procedures for the open Bankert repair. He describes the longitudinal split of the subscapularis and the capsule, and they make double breasting or lateral advancement of the subscapularis and the medial advancement of the capsule. And after that, a lot of modification come on this technique, but it limits the external rotation. Ruppert and Green describe a modification of Magnuson's technique. He reattaches the subscapularis more lateral and more inferior to the bicipital groove, which make 3 action. Prevent humeral head, prevent subscapularis from slip over the humeral head on the external rotation and the abduction. And it resists downward and forward pull. And it rolls the humerus posteriorly when the arm is elevated. Connelly operation, he described the filling defect of the humeral head by the infraspinatus through the posterior approach and drill the bone extracapsular by open procedures. which nowadays is known as rumble surgery. Near capsular shift, Near and Forston on 1980, they described capsular shift through laterally based T incision at the capsule, and after that they slip this flap lateral and superior. That was 3% recurrent rate. And Altic et al. On 1991, they described the same modification, but make this T is slight medially. Now the bony procedures. Eden on 1918, he describes the use of tibial graft as a wedge on the glenoid defect, and Habenet on 1932, he used the iliac crest graft, and after that, Longe makes some modification on this technique by fixing the bone graft with screw or tacks and make shortening of the subscapularis with 70% recurrent as Whedon on 1948. Presto, he is the first one described coracoid transfer on 1939 and published by Helfet on 1958. They osteotomize the tip of the coracoid and go through the window on the subscapularis and fix it on the glenoid. After that, Letorget in 1954, he modified the Presto technique. He takes the osteotomy to the base of the coracoid and through the subscapularis, he fixes it at the glenoid, so increase the surface area of the glenoid and use dynamic sling by the conjoint tendon. After that, Saha osteotomy in 1961, he describes the derotation osteotomy. He makes zero position for the humeral head, so decrease the external rotation range of the humeral head, so he prevents the shoulder dislocation. After that, Whipper on 1964 and the reported procedure in 1969, he take a humeral shaft osteotomy and he internally rotates the proximal part of the humerus, so he decrease the external rotation range, so he prevent the shoulder dislocation with 60% recurrent rate. Meyer procedures on 1967, he describes the glenoid osteotomy. He increased the retroversion of the glenoid, so he prevents anterior shoulder dislocation. Arthroscopic procedures start with Johnson on 1980. He described the shoulder stabilization using staples. Staple is very easy technique, but high recurrence because no tension or no shifting of the tissues on the glenoid, and they lose hardware. After that, the glenoid suture was the glenoid transglenoid technique. First, Morgan on 1987, he described draining two tunnel, pass from anterior to posterior and tie posterior, but a little tension was on the repair here on the anterior part. So Kaspari in 1988, he described single tunnel with Kaspari punished needle, but add more tension on the anterior repair. At the time of development, it was major improvement, but later unacceptable recurrence. Thermal on 1990, first described. It's very easy technique. They use diathermy and make shrinkage for the tissue, but no published data or clinical outcome we can discover except complication, axillary nerve injury, capsular necrosis, increased recurrence, difficult revision, stiffness, and etc. etc. Reabsorbable tax first described BGA, polyglycolic acid implants by Werner at 1991, but it was rapidly absorbed, so you lose all tension on the sutures here, and loss of strength, and serious soft tissue reaction as Buchart and et al. At 2000 described, and Change et al. At 1997 described. Reabsorbable tax now advantage to PLA, polylactic acid, or combination between polylactic acid and BGA. The absorption is delayed and the tissue reaction more or less, but it looks like a staple and invisible by X-ray, as Berger described in 1996, and more expensive. Suture anchor, Wolf in 1993, and modified by Sander, described suture anchor first. Suture anchor allows solid fixation of the soft tissue to the bone, and the knot is challenging, sliding knot and a lot of knots type. Thiel in 2001, he described the knotless suture anchors. And even the suture have a lot of evolution from BDS to Ethi bond to fiber wire, tiger wire, and ultra braid, a lot of sutures now. Suture anchors, it's some type of sutures. It's corkscrew, genesis, helix, biabsorbable suture anchor, helicoil, 20 fix. The literature talk about the recurrence. Saviotel 8% in 1990, Bukhart 2004%, Romeo 0%, Chemical and at 2003 4%, etc., etc. Overlap arthroscopic banker technique, as Dr. Bassem described in 1996 in GOS Hospital of Bonn. I think Dr. Bassem will talk about this technique by details. He used shuttling suture and reattaches capsular labral tissue by suturing at the anterior glenoid, procedure without any implants. And also Dr. Bassem described at 2001 arthroscopic L-shaped inferior capsular shift. He do an L-shaped incision here on the inferior part of the capsule and make implication or reinforcement of the capsule at the subscapularis. After that arthroscopic laterally, Jeffrey at 2003 he described on the cadaveric, who's assisted many open, but the first one was the French Bolio and Lornet in 2006, and even Lafosse described using beach chair technique and position and use 2 screws. Arthroscopic remplissage, first described by Borges and Utel in 2008. He described use 1 anchor or 2 anchors. This is from posterior through the infraspinatus and advance the infraspinatus to fill the defect. And this is the final picture. Even we have still evolution on the shoulder surgery and the technique. And thank you.
Thank you very much, Dr. Hani, for this very elegant presentation. Now, Dr. Oliver Verboch will talk about arthroscopic suture anchor repair for recurrent anterior dislocation, shoulder, and without banker with and without banker lesion. Go ahead, Dr. Oliver.
Right, so good evening, everybody, and thank you for this second invitation to this extremely successful webinar, and my congratulations to the organizing committee. If we talk about shoulder instability and anterior shoulder instability, of course, the essential anatomy is the capsulo-labral complex. As you know, specifically the inferior glenohumeral ligament is composed of 2 bands, an anterior and a posterior band, which makes it a sort of a hammock-like structure that specifically tightens in abduction and external rotation. When a recurrent shoulder dislocation has taken place, basically it's a detachment of that specific hammock on the glenoid side that is the most common problem when we talk about anterior instability. Historically, the best surgical repair for this lesion was an open Bankart repair with important and capsular shift. And this was a very efficient and successful surgery for many athletes that have been treated by this many times. Since 2 decades or so, this exact same technique has now been reproduced in an arthroscopic technique, but the same principles are important. Mainly, it's a repair of the labrum plus a shift of the anteroinferior capsule. This is usually done using conventional techniques with 3 to 4 portals, 2 to 3 cannulas, depending on your technique, and the use of suture anchors. And this is done using metallic, bioabsorbable, or something in between, meaning the biostable anchors such as PEEK. And in this way, it's possible, just like you see on this arthroscopic video, to anatomically repair the lesion in this first-time dislocator, a young goalkeeper of 18 years old. The results historically have been very successful, especially in the first decade of this century. Many authors have reported a low rate of recurrence, as you can see here. On the other hand, as we followed the results much longer and longer-term follow-up became clear that the success rate was not that good as we estimated they were, with some people reporting up to 35% of recurrence rates when with longer follow-up. In a known data set in a population in patients with recurrent anterior instability without bone loss, we found in our own series recurrence rates up to 9%, which is a very acceptable rate. But when we stratified them to contact sports, we found that up to 20% had a recurrence of their dislocation. This is an example of I would say, a contact sport. This is a professional judoka who is defending his European Championship title. He's in blue, and as you can see here, he has a recurrent anterior dislocation of the left shoulder. He had an arthroscopic repair done many years ago, and now he has this recurrence. This is his post-trauma arthro-CT, and as you can see, the labrum is still intact, but like in many cases, it's just the whole anterior capsule that has been torn off. And this is important to understand that arthroscopic soft tissue repair is not only the labrum, but it's also the capsule that needs to be repaired well. For this type of injuries and this type of athletes, high contact athletes, we think that there is only one solution, which is the Latarjet procedure, is the bony procedure. And I think nowadays in this type of patients, we would do the exact same operation for the first time as well. So no arthroscopic soft tissue repair in this type of contact athletes anymore. Other people have looked at predisposing factors for failures after arthroscopic Bankart repairs. And as you know, there are specific pathoanatomic considerations, but also patient-related situations. And for me, bony defects and the extent of the capsular lesions are very important. Implant failures, but also surgical error or poor healing are important factors to consider. I think the technique is important. And like I said, it's not just only a labrum repair, but it's also the capsular shift. It's tightening of the whole antero-inferior capsulolabral complex, as you can see here, so that it's really stabilizing the whole anterior-inferior part of the shoulder. And this is something that is very important when you perform an arthroscopic Bankart repair. In some cases, there is no Bankart lesion, like in this one, where there's just laxity with anterior instability. And it's exactly the same principle where you will grab part of the anterior capsule, the soft tissue, and put some loose sutures, single sutures, to repair the capsulorabral complex. Again, just like you see here, many sutures on the anterior-inferior parts, and even on the posterior-superior, on the posterior-inferior part as well. We put some extra stitches, and this would be the end result in a patient with recurrent instability without a Bankart lesion. And as you can see, we do an important shift of the capsule of the anterior-inferior part, but also of the posterior-inferior part, which stabilizes that shoulder well in a patient without a Bankart lesion. This type of repairs can be done with simple sutures alone, but also using the newer type of suture anchors. And this newer type of suture anchors, we do use them as well here as in the standard Bankart repairs. As you can see, they're very fine and precise. They are much less invasive to the bone and are very efficient. The question is, why would we switch from the traditional anchors? Here's a patient that had an arthroscopic Bankart repair done with metallic anchors, as you can see, 6 months before this X-ray, when he started to have pain and grinding symptoms, locking symptoms. As you can see, there's an ongoing arthritis. And on arthro-CT, you can see that one of those metallic anchors is just 1 millimeter broad on the articular surface. When we scoped this patient immediately, this is already the damage that has been done by one of those anchors that is just a couple of millimeters above the articular surface. The surgery was not done in our institution, we do not use these type of metallic anchors anymore. As you can see, they can be very harmful to the cartilage. So I think this is one of the reasons why we like to use all suture anchors. There is no metal in the anchor. It's much less aggressive to the joints. It relies on cortical bone fixation, where it deploys on the glenoid rim. The pull-out strength is comparable to classic suture anchors, and you can also use them in a percutaneous technique. The results have been very successful so far, with a very comparable clinical outcome to classic suture anchors, with recurrence rates we have reported to 7%. And the small bone cysts that you see once in a while on post-operative MRIs, as you can see one here, do not have any clinical implication in our study population. This is an example of one of those patients where you can see there's a very small drill guides used, 1.4 millimeter drill guide and drill pin used. Makes a very tiny hole on the rim of the anterior inferior part of the cartilage. The anchor is introduced, and it's just very specific and very fine technique, as you can see here. It's actually also very stable. When we pull on this, it's quite stable. As you can see here, it's a great pull out. It's as strong as a classical suture anchor. The other advantage of this is that it can be used percutaneous, as you can see here, for a posterior labrum repair with a classic cannula on the posterior inferior part. And then we use a needle to determine the right position of the entrance, make a small stab incisions, and then bring in that all suture anchor through that small stab incision. And as you can see, this now can be used as almost as a percutaneous technique, where multiple anchors can be introduced through a very small incision. So in conclusion, for me, suture anchor repair for recurrent anterior instability, for no contact sports, no bony lesions, and a good capsule, this is the best indication for soft tissue arthroscopic bankart repair. And I think bankart repair is a labrum repair with capsular shift. When there are important bony lesions, patients that do contact sports and in revisions, a bony procedure is much more reliable. When we speak about the different types of anchors, classic suture anchors can still be used, but I do not recommend to use metallic anchors anymore in the glenohumeral joints. When you insert suture anchors, make sure that you use a meticulous insertion technique, that they're not proud. Even the peak anchors, this can damage the cartilage quite fast. And if there are any locking or grinding symptoms in the patient postoperatively, act fast and do a rescope. I prefer today to do all my bankart repairs arthroscopic using an all suture anchor. I think it avoids an anchor-related complication. It's much more minimal invasive, and it's an easy technique. Thank you very much for your attention.
Thank you very much, Dr. Oliver, for this very nice presentation. The coming presentation, Dr. Mohammed Al-Assasi from Cairo, under the title Arthroscopic Anterior Cruciate Repair and Inferior Capsular Shift for Recurrent Anterior Dislocation with and without bankart lesions. Go ahead, Dr. Mohammed.
Thank you, Dr. Yasser. Welcome our guest speaker. I will speak about anterior capsular shift for recurrent anterior instability shoulder. Indication of inferior capsular shift: shoulder instability due to capsular ligamentous laxity or secondary redundancy. In absence or after repair of bankart lesion, in cases of HAG, humeral avulsion of the glenohumeral ligament, or anterior labral periosteal sleeve avulsion collapse. Contraindication: voluntary instability, poor patient compliance, inadequate capsular integrity. The main pathology in the recurrent anterior shoulder instability is plastic deformation of the glenohumeral ligament is the main prominent factor in recurrent instability. Denied bone classification classifies the pancreas without bone loss in 6 types. As we see, the main factor in this classification is redundancy and laxity. Treatment: open and anterior and posterior inferior capsular shift, described by Neer in 1985. First step was close the interval. Second step, T-incision, vertical along the neck, horizontal between the middle glenohumeral and the inferior glenohumeral ligament. C, curate and the bleeding sulcus on the anterior neck. D, crochet closure and reinforce the capsule. The results published by Neer with 75 to 95, 100% good to excellent results. 50, 100% to 80, 100% return to normal function with minimal pain. Poor return to overhead throwing activity. Arthroscopic anterior and posterior inferior capsular shift, described by Dr. Bassett-Lega in 1996. The first step was a braid sulcus of the humeral neck. Second step, vertical incision along the neck. Third step, horizontal incision between the middle glenohumeral ligament and the inferior glenohumeral ligament. Fourth step, crochet closure and reinforce the capsule. Results published in 2012 in the American Journal of Sport Medicine by Dr. Bassett-Lega and Dr. Shewy. The results was 95, 100% good to excellent results. 98, 100% return to function with minimal pain. All patients return to overhead and throwing activities. 10, 100% with minimal pain only. Goal of arthroscopic inferior capsular shift is decrease the excessive translation in the symptomatic direction to create a functionally stable shoulder, and creating a balance with centered head, inevitable shortening and strengthening of the capsule through cutting, better capsular quality by doubling the width of the capsule through overlapping. In summary, the goal of arthroscopic inferior capsular shift: decrease translation of the head, centralization of the head, shortening and strengthening of the capsule, better capsular quality. Arthroscopic inferior capsular shift technique. First step, examination under anesthesia to know the magnitude and direction of the glenohumeral translation, and here it is anterior and recurrent anterior shoulder instability. 2, patient positioning, sitting position with the arm hanging free to get normal range of motion. Instrument, shop needle and suture passer. Portals, posterior portal, standard posterior portal, 1 cm inferior and 2 cm medial to the postlateral corner of the acromion, and the anterior portal, 1.5 cm lateral and 1.5 cm inferior to the tip of the coracoid. Fourth step is a braid and refreshment of the sulcus of the anterior of the head. Electrical cutter, using to do an L-shaped incision to make the flap. One along the vertical incision along the head, and the horizontal incision between the middle and the inferior glenohumeral ligament. Then a suture passer or shop needle pass through the flap with the suture. Then suture puller, retract the suture and pass through the lateral end of the subscapularis. Then tying the suture. 3-in-1 knot. Close the open rotator interval, superior shift of the half anterior and inferior capsule, doubling the width of the anterior capsule. Observe the head centralization pre-operative on the left and post-operative on the right. You can see the distance between the head and the glenoid, the far distance, and here on the right side after tying the knot, the glenoid the head is very close to the glenoid and center to the glenoid. Arthroscopic inferior capsular shift technique: control centralization of the humeral head, closure of the anterior inferior or posterior inferior capsular pouch, stability of the secondary side. Post-operative management: immobilization in a cast or a special brace in 0-degree rotation and 15-degree abduction for 6 weeks. This is the milestone for normal range of motion. arthroscopic inferior capsular shift, cheap, relative short-time surgery with no disposables, learning curve is middle, high rate of post-operative normal function, post-operative immobilization for 6 weeks is mandatory. Thank you.
Thank you very much. Thank you very much, Dr. Muhammad, for this very nice presentation. The current presentation about Dr. Ahmed Andil for Alexandria University. It will be on Dr. Ahmed Andil, treatment of complicated and failed reconstruction of anterior shoulder dislocation. Go ahead, Dr. Ahmed.
Yes, good morning, everybody. Good afternoon or good evening, according to your time zone. So I'll start right now. So treatment of complicated and failed reconstruction of anterior shoulder dislocation. We all know that ligamentocapsular structure is attached on the glenoid and humeral sides to form some sort of hammock on which lies the humeral head. And Bankert lesion means detachment of the hammock from the glenoid side. Open or arthroscopic Bankert repair was the standard treatment of anterior shoulder dislocation. But how far this is true? Many authors found that failure after open Bankert repair was high. It may reach up to 17%. And the same story after arthroscopic Bankert repair. It may reach up to 50% of the cases. So they start to ask questions. Why do we have such a high failure rate? And who are the patients who are at risk for failure after Bankert repair? Is there another lesion that wasn't recognized and has not been treated? And so they look for other treatment options. One of these surgeons is Pascal Boileau, who just studied in 2007 a cohort of 131 patients treated with Bankert repair. And he found that failure of Bankert repair was about 15%. So he looked into some risk factors like young age, type of sport, either contact or forced overhead sports, the level of sport practice, either competition or recreational, the presence or absence of hyperlaxity, presence of heel sacs, presence of glenoid bone loss. And he gathered all that in a table and just he puts points for this. And he introduced to us something called the Instability Severity Index score. And he found that patients who had less than 3 points, the instability recurrence rate was 5%, which was acceptable. But those with more than 3 points, they had an instability recurrence rate about 70%, which was not acceptable. So he concluded that when ISO score is less than 3, the patient is a good candidate for Bankert repair. But when it's more than 3, this is a formal contraindication for Bankert. From the previous data, we found that the contraindication of Bankert repair may be the following. Like in patients who are indulged in extreme sports activity, like rugby, martial arts, etc., or patients with failed previous stabilization surgery who needs revision surgery, either Bankert or remplissage or whatever, or patients who have a poor ligament quality or Hagel lesion or disrupted or thin capsule. So in this patient, if we do a Bankert repair, it will fail. As you can see in this video, Hagel lesion. Or the presence of big bone loss, either on the humeral side, like a big heel sacs, or on the glenoid side, or sometimes on both sides, which we call bipolar lesion. A significant bone loss, it's a term which was introduced by Burkett de Boer in 2000 when they discovered an inverted pear-shaped glenoid. When there is a bone loss, more than 25% of the inferior glenoid diameter. And this led to engagement of the heel sacs in 90-90 position, and of course, dislocation. Another term which was introduced by Yamamoto and Ito in 2007, which is the glenoid tract that's defined as the area of contact of the humerus against the glenoid goes up. From cadaveric study, Yamamoto showed us that the glenoid pushes the cuff about 16% of the glenoid width. And so the glenoid track is about 84% of the glenoid width measured from rotator cuff attachment. It goes without saying that when there is a glenoid bone loss, the glenoid track narrows. So to measure the glenoid track, we just measure the 84% of the normal glenoid width. And then from this measurement, we subtract the glenoid defect width to have the glenoid track of a certain individual. Di Giacomo et al. In 2014, they published an interesting paper titled Evolving Concept of the Hill-Sachs Lesions from Engaging Non-Engaging Lesion to On-Track and Off-Track Lesion. So in this paper, they showed that if the Hill-Sachs is within the margin of the glenoid tract, so no engagement and no dislocation, and we call it as an on-track lesion. And on the right side image, if the medial margin of the Hill-Sachs extends beyond the glenoid tract, so there will be engagement during abduction external rotation, of course dislocation, and we call this an off-track lesion. Omori et al. Found that the glenoid tract is not 84%, but it's 83% of the glenoid width. And of course, when we do a 3D CT scan, we can just do the measurements and calculate the glenoid tract. So Di Giacomo, he just introduced the treatment paradigm. They divided the patients into 4 groups. Group 1, when there is a glenoid defect less than 25%, and on-track Hill-Sachs lesion, we can do arthroscopic Bankert repair. But in other cases or other groups, arthroscopic Bankert repair would be inferior. So if we have off-track Hill-Sachs lesion or a glenoid defect more than 25% or both, now we cannot do arthroscopic Bankert repair, but we should treat these patients with another option like remplissage, Latarjet, or even Latarjet remplissage, which is almost never needed as they mentioned in their paper. So it's very important. Pre-operative and intraoperative planning is very important. And we should ask what's the kind of the lesion? Is it a soft tissue lesion, a bony lesion, or we have both kinds of lesions? And in case of bony lesion, where its location, in the humeral side, on the glenoid side, or do we have a bipolar lesion? My preferred method of treatment in such complicated or failed cases, I do Latarjet procedure after Michel Latarjet, who just invented this procedure in 1954, and it has a bone block effect plus the sling effect of the conjoint tendon. I had the chance to do a 2-year fellowship with Laurent Lafosse, who invented it to do it arthroscopically, and I'll show you just an animation how we do it arthroscopic in open technique. So we have, this is the coracoid, this is the C ligament, we detach it from the coracoid, the pec minor, we detach it also from the coracoid, switching stick from the posterior portal to identify the site of the subscap split, we do the split, and then from a superior portal, we introduce this instrument with 2 K-wires and then 2 drill bits to make 2 holes. And then we pass the chair through the holes and take it, the 2 limbs from the superior portal. We introduce something called the top hats to increase the purchase of the screws. And then from anterior portal, we introduce this instrument to retrieve the 2 suture limbs, the 2 limbs of the chair, sorry. And then after that, we do a osteotomy of the coracoid to attach the coracoid to this instrument by 2 long screws. And then we pass it through the subscap split to make sure that it is well applied on the anterior surface of the glenoid. And then K-wires followed by cannulated drill bits and cannulated screw in the inferior hole, as you can see. And we repeat the same thing with the superior hole. Cannulated drill bit through the K-wire, we make the hole, and then we introduce our cannulated screw through the superior hole. We make sure that the coracoid is flush with the glenoid, and then we remove everything. This is a arthroscopic image, how we do it. This is the the humerus, the glenoid, this is the coracoid, and we can see here the screw through the superior hole. This is the final picture after screwing it. This is the coracoid, the two screws, as you can see, the humeral head and the glenoid, and it's well flush with the glenoid surface. Another arthroscopic image, the glenoid, humeral head, the two screws, and you can see the conjoint tendon passing through the subscap split, and the coracoid graft is well flush with the glenoid surface. This is one of my cases after 1 year. You can see the image pre and post operatively, and the CT, which shows a very good healing of the coracoid graft. As regard the results, more than 50 patients into the mean follow-up of about 34 months. The return to work after 2 months on sport, after 2.5 months, 94% had excellent results. The range of motion, we have like average loss of external rotation of about 18 degrees or less. And as regard the complications, 1 hematoma, 1 graft fracture, and 1 case of transient musculocutaneous nerve palsy, which recurred after a few months. And for the late complication, we had 4 cases of graft non-union and 3 cases of graft lysis. But surprisingly, none of these patients had an episode of dislocation or apprehension. Graft position was flush with the glenoid in 91%, and vertical position was excellent in 94% of the cases. We all know that Latarjet is being criticized as being a non-anatomical reconstruction, but actually, this surgery is very successful to reduce apprehension and recurrence as much as possible, and to return to full sport activity. So, in summary, patient history is very crucial, like age, type of sport, level of sport, etc. It's very important to have an intraoperative assessment as pre-operative assessment, because sometimes when we go inside, we may change the decision from bankrupt repair to Latarjet if we find, for instance, a thin capsule or defect labrum. CT should be done in every case of shoulder dislocation to detect bony lesion. This is very important because Segai et al. In 2003, she showed us that about 90% of cases with anterior shoulder dislocation have bony lesions. Thank you very much.
Thank you very much, Dr. Ahmed Natif, for this very nice presentation. We have a lot of questions for the speakers. Now, Dr. Bassem Frega will present a talk about anchorless treatment of complicated cases and failed reconstruction of anterior shoulder dislocation. Dr. Bassem?
Good evening. I will talk about the material for this presentation gathered from the GOC Shoulder Hospital in Bonn, Germany, Al Salam International Hospital in Cairo, and Dar al Fuad Hospital in Giza, Egypt. Between 2013 and 2019, we had 876 cases of recurrent anterior dislocation. All of them had an inferior capsular shift, 220 with an overlap Bankert repair, and 44 with shift-sick Bankert repair, and there were 54 cases of revision. The treatment and results were very good, excellent in most of the cases. The strategy of the surgical treatment is to define the lesion, establish a healing potential, a healing site, and anatomic repair of soft tissue lesion to the labrum, rotator interval, capsule, or rotator cup, and reconstruction of bony lesions. Also avoid injury to normal tissue. The frequency of the lesions are 90% elongation or redundancy of the capsule, avulsion of the labrum in average 30% of the cases, a Bankart lesion, and very rarely a tear of the capsule or a Hagel lesion. Up to the early 80s, there were more than 100 surgical techniques of recurrent anterior shoulder dislocation. In the late 70s, it was crystallized on Bankart repair, but the results were not very satisfactory. Charles Neer, in the beginning of the 80s, he introduced the reconstruction of the anatomy as a golden standard for repair. It was based on repairing a labrum avulsion or a Bankart lesion with a Bankart repair, enlarged capsule volume with the inferior capsular shift, and treating the glenoid defects with either a bone block or a Bristow or Latarjet, and the large Hill-Sachs lesion with the bone block. The inferior capsular shift was described by my fellows before. Also, Carter Rowe has modified the Bankart repair by making a vertical incision in the capsule and thus making a vertical shift to the anterior capsule. As I said, also the Bristow and Latarjet and bone block for the defects. In the era of arthroscopic treatment of the recurrent anterior dislocation, which was done in the beginning with Elleman, noticed that the problem in the treatment was not addressing the anterior capsule. And this was also proven in many studies done according to that. So this problem first was treated then with an arthroscopic plication, which is making a medial capsular shift to the Bankart repair in order to shorten the anterior capsule. Also, closing the rotator interval, if it is wide, has added to the anterior stability. The arthroscopic inferior capsular shift, as said before, was used in the late 90s. It is an arthroscopic treatment of the simulating the inferior capsular shift described by Neer. It is done by making a horizontal incision between the inferior and the middle glenohumeral ligament, then a vertical incision, and then pushing a suture through the flap and pulling the flap upwards and shortening and doubling the anterior capsule. Very important is an anatomical post-operative immobilization. Put the shoulder in its neutral anatomical position in order to have the healing of the capsule, giving the same size vertically and horizontally of the anterior capsule. The pathologies found are mostly hyperlaxia and redundancy in 95% of the cases, associated with Bankart repair in 32%. Bankart lesion alone was in 5% of the cases. Rarely were bone defects. Another lesions were also present, but they didn't change on the major strategy of the treatment. The overlap Bankart repair is used to fix the labrum to the anterior glenoid rim with sutures by making a hole in the anterior glenoid rim, passing a suture with a so-called PS wire, the wire with the suture in the anterior, and then tying the labrum to the anterior glenoid rim. Here we see, after abrasion of the anterior glenoid, the wire pushed from the back and make a hole, and then the suture is passed through, pulled through the labrum, and then tied to the glenoid. This is on the left before surgery, the MRI, and on the right after surgery, showing the complete healing of the labrum. In 1999 have published that putting the shoulder in external rotation in case of first dislocation have better results than internal rotation. That was because when putting on the capsule, you pull the labrum back to the anterior glenoid, and in the first time dislocation, the anterior glenoid is still bleeding, so immobilizing it in external rotation lead to healing of the labrum to the glenoid. This inspired us to use this technique by creating a bleeding surface on the anterior glenoid and then doing an inferior capsular shift. This is in case of recurrent dislocation, and thus pulling the laterally and having the same effect as the external rotation and immobilizing the shoulder. This is a case pre-operative and post-operative 6 months later. In case of bony Bankert, with the same transosseous repair as we do for the labrum, the over labrum repair by putting the suture through the anterior glenoid and then through the labrum and then tying the broken fragment back to the glenoid. Here we see the fracture, and after passing the suture through the glenoid and the lumbar, then tying it back. In case of a defect in the anterior glenoid, larger F, you use a bone block or lateral J. In lesion, more than 10%, we did the remplaçage, but recently we have the patients have problems with that, and we try as much as possible not to use it by making a solid anterior capsular reconstruction. Also, if the Gel-Sac lesion is large, we put a bone block arthroscopically. The bone block will be cut according to the size of the Gel-Sac, and it will be pulled with sutures inside. As we see here on the monitor, the bone block is in the Gel-Sac defect. It will be tied then with sutures. In case of an Hagel lesion, also we fix the Hagel lesion with the wire and the suture by making a mattress suture through the anterior labrum and tying it from behind. In old patients, fracture of the greater porosity or posterior rotator cuff tear is not uncommon. So we have to look for that and take care to treat that. In case of open rotator interval, we suture the interval using the giant needle, or by making, if we make an inferior capsular shift, which is most of the cases, we also interval with it. This is a case of a failed repair, complicated by osteoarthritis, as was mentioned also before from my colleagues. And here we remove the anchors and make a slabage surgery. This is also a Bankert repair, and there's a disturbance of the blood supply to the cartilage leading to osteoarthritis. There's another case with complete osteoarthritis, which ended by total shoulder replacement. Here's an anchor case with damage to the glenoid and fracture of the glenoid. And this is also a case with a recurrent due to capsular redundancy and supraspinatus lesion, which was not treated. And this caused a damage also to the head. It was repaired by repairing the supraspinatus, suturing that transosseously, and then making an inferior capsular shift. It is also a recurrent case. We see the sutures from the anchors are then removed, making bleeding surface anterior acromion, suture through the anterior glenohumeral ligament and tie the labrum back to the glenoid. And after that, we do then, here's a tying, then we do the inferior capsular shift. This is another case of a loose ankle which has damaged the shoulder, and here's the head with the damage. We did then an inferior capsular shift and abrasion to the head. And this is the ankles which we removed, and the patient 1 year after surgery completely satisfies the normal range of motion. This is an 18-year-old patient who had an operation for a Bankert lesion or recurrent anterior dislocation. And the anchors caused also damage to the joint with infection. And the joint was unfortunately completely damaged, so that a salvage operation with the removal of the anchors and arthroscopic debridement didn't help. And he got a total shoulder replacement. He is now satisfied, good range of motion, no pain, but we hope this will stay for a long time. We gathered from the literature 998 cases of Bankert repair with application. And we found that the redislocation, these cases were average 9.3%. Compared to the cases which we did, it was 0.35%. Also, the function and athletic activity was regained in the group in 55% completely, while in this group of the anatomical reconstruction in 95% of the cases. In summary, it is only one thing I want to say, that it's arthroscopic reconstruction of the anatomy, as Neil said, in the 80s, and this is actually our experience and brings the best results. Thank you very much.
Thank you very much, Dr. Bassem Fliega. Now, Dr. Kovacs from Germany will present post-operative competitive athletic performance after reconstruction procedures for recurrent shoulder dislocation, anterior shoulder dislocation. Go ahead, please.
Yes. Thank you very much for the invitation. Can somebody put my presentation on the beginning, please? That's not the beginning.
We want the beginning of the presentation, please, Dr. Ustaz Abdelaziz. أول presentation أولها خالص. أيوه. لسه دي مش أولها. تمام. أيوه دي كويسة.
Okay, thank you very much for the invitation, Dr. Fliega, and for the second time. I want to speak about a painful shoulder in the competitive swimmers because we are institute with a lot of high-level performance athletes, and I think the swimming athletes, they are some problem for the instability, because they need from one side hyperlaxity, from the other side they need strong muscles, and the trainings performance is very high by them. So what should you know about the swimmers? It's an endurance sport. They swim at the elite level. Each swimmer must log between 30 and 80,000 meters per week, which is equivalent to 30,000 strokes per arm. So fundamentally, the swimmer stroke requires the shoulder at range of motion extremes while tendinous muscle force extend up on the shoulder. The next, please. So what's the problem? The problem is from one side, the anatomy. They need an adequate swimmer body, the muscle quality of type and the acromial space, the quality of tendons and the cartilage and the labrums, and of course the position of the labrum. Otherwise, is of course that the physical burden. They trained 5 to 8 hours per day. They had a very strong competition scheduling, rehabilitations deficit, the time zone difference, and a lot of times inadequate physio. So for the third, another side is the expectation from the competitions result, from the motivation, from the sport, and cap. The cap I'll come back later. The next, please. So medicals of shoulder pain in the face are required one problem is the muscle fatigue plays a pivot role and the etiology of many cases of femur shoulder. The next, please. So the anatomy, the impingement is well known. I use the Lione classification from the impingement. The next, just for the basics, the same. The next, please. So the glandular instability is common in young athletes. Also, a dislocation event is defined as a complete dislocation of the articulate surface that requires a manual reduction maneuver. Transient luxation can also occur with spontaneous reduction of the humeral head. The next, just the basics. This geometry provides functional benefits by allowing for a large arc of motion, but also confers an inherent instability that can result in pain or in dislocation, tears. But this geometry and this large arc of motion is needed in the swimmers because this hyperlaxity is one of the part of the femur's body. In fact, the incidence of traumatic shoulder instability has been reported to 1.7% in the general population. And in fact, the most common type of glandular instability is in an anterior shoulder instability. The next, please. So, the hyperlaxity itself is not a serious pathological defect, but as I saw it's needed in the swimmers. The next, please. So we all know the static and dynamic stabilizers. So of course, in our cases, the rotator cuff defects and labrum defects or tears are in focus. The next, please. So because we have, from the other side, the anatomical factors like glenoid type, acromion type, and of quality of tendons, and that's very important because if the quality of the tendons, if the fatigue and the connective tissue and the fatigue percentage is not good for these high-level sport athletes. They have pain, and the pain is a problem if you need the 5% more performance, more power in the competition. From other sides, we have, of course, the sport technical and iatrogen factors. We have the problems from the society, the technique, and the cap. I'm coming back later. And of course, the injuries what they have many times. The next, please. The say intrinsic reasons, what I mentioned. So CAP is the coach, athlete, and parents problem. Of course, we have the overloading questions and the technique. Why is so important this CAP? Because you as a doctor, you are sitting with the parents, with the trainer, and with the athlete 6 months before the Olympic Games or World Championships. So the athlete has a labrum tear, not that much, and has a incomplete tear. So you say, okay, you need a surgery, and the parents say no. The first my son, they have to go to the Olympic Games. So it's not an easy situation to explain what's more important, to go first time to the Olympic Games in your life, or to have a surgery and to can compete the next 2 or 4 years. The next one, please. Yes. So this is the CAP, the hyper motivation of the coach, the strong motivation of the athletes, and the hyper motivation of the parents. The parents, sometimes it's very difficult to explain what's the 21-year high level athlete has. Of course, they have contracts. There's a number of competitions, and in some cases and countries, we have an inadequate medical care support for this high-level sports. So, of course, there's an imperfect technique what can be or a wrong stroke technique, or overloading, the short rehabilitation time. You say, okay, after the labrum refixation, you need 6 weeks immobilization. The trainer say, no way. After 3 weeks, he should make training. So they have to deal with this inadequate medical or physical care or support in a lot of times. The next, please. So what's the pressure for in this case is that we have a primary expectations, pressure from the society, friends, media. Hey, you should be the #1 in the world. They have a basic expectation from parents, from a girlfriend, from the family, and the current situations pressure, the self-generated situation and the ambient pressure. If you are in stadium with 55,000 people, it's a pressure. It's a positive or a negative, but it's a pressure. The next one, please. So this is the examination. What we do, we are looking for the normal range of motion or the abnormal range of motion. But if these guys has therapy resistance or pain resistance, I think we should consider an arthroscopy. And if they have the labral tear, and I think they need a surgery too. The next, please. So we use an MRI or CT if it's a Bankart lesion, or ultrasound and X-ray need a normal examination. The next, please. So this is the easy case. The labrum is ruptured. The supraspinatus rupture is there. So we don't. It's not a question. These athletes need a surgery. The next one. Supraspinatus rupture in ultrasound and a clear situation on your right. The next. This is the problem. The labrum bruise. It's not a full tear. this is a situation. What's the question? What should you do 6 months before the Olympic Games? He has pain after 2 hours. So the training is 3 hours. So and the swimmers has one time in their life possibility to go to the Olympic Games. Should he make a surgery or not? Because if you make a surgery, it's difficult to come back on the same level. The next, please. Partial tears, painful. They can be painful. With a small labrum, this bruise too. But this is the typical case, which is difficult to explain. Okay, you don't have any time pain. You have sometimes pain, but if in a competition you need 110% from your power, so with the pain you can't have more than 90% of your power. The next, please. Yes, the next. This is the both situation. So if you have an anterior and posterior labrum tear and with a bone defect, as you see on your right, it's yes. I think in this case, these athletes don't have any chance to go to the World Championships because they have pain, and this is unstable. The next, please. So we put a stitch in the posterior labrum defect 2. The next, please. So unfortunately, I can't show you the film which was here. It's we make by all these athletes a video, and we analyze what's the problem in the technique and what's the problem and the freestyle stroke. And what we see by the labrum defects, that the last 20 centimeters, they make the whole stroke, the whole movement correctly, and the last 20 centimeters, they can't push the next step. And they lose 10–12% from the power what they have. And the next, please. And that's the number. That's the difference between the number 1 and the number 8 in the World Championship situation. The next, please. So we try, of course, first non-surgically and with all the techniques and injection and cell therapies and. But if they have a pain persistence, the solution is surgically, and is appropriate for structural pathologies and tears, but not for functional one. If the movement is bad, if they overloading, then they have to make a break, and they don't need a surgery. The next, please. So for a swimmer with persistent pain, multi-directional instability, inferior capsular shift, persistent subacromial impingement, labral tear or bruise, rotator cuff tears and bruise, and treatment-resistant pain, need a surgery. In the literature, I see results between 75 to 80% to return to the same level. I think the higher the level is, the more is a percentage. I think the high level athletes is 90–95% to return on the same level. We made the surgery in one session. If the rotator cuff has a partial rupture or rupture and the labrum, we make this surgery in one session. And I think it's they have a break, so and they are motivated, and I think we have with this solution extremely good results. The next, please. So this is on your left. This is a labrum tear, incomplete tear. It's not a perfect rupture. It's a bruise, bleeding, but it's painful. And if they trained 5 to 8 hours per day, so it won't be better. So in this case, we make the sutures. I use the Flager technique and the anchors too, depend of the anatomical situation. The next, please. The next, yeah. Okay, so using a giant needle technique in a small incomplete tear on the same situation. The next. The next, please. So the range of the pathology in femur shoulder because of the upper body generates 90% of the propulsive force to 1 million strokes per year. Femur coach clinicians should avoid using the term femur shoulders because these non-specific terms actually encompasses a loss of injuries. I don't like this femur shoulder term. The next, please. The further research focus on the diagnosis and prevent the shoulder injury in athletes because the comeback to the same level is not always easy. In contact sports is difficult. An improved understanding of the scapular dyskinesis may influence coaches to structure training sessions in ways that reduce an athlete's exposure to dangerous techniques. The next, please. So, because what's the athlete's way? It's depend of in the middle, the triangle is the success. So they need a good anatomy, femur's anatomy, and muscle type, medical support, and the cap and body stress. They have to deal with this situation, and they can have success. The next one, please. But the success is bigger, but in champions' ways. If they has a better anatomy or genetic, and they can all this pressure, body stress, deal better than the other ones, and they have a medical support. They are the champions, and you see the triangle is bigger than the swimmer's way. The next one. And this is the situation what we don't want, to have the doping's way to the championship with a high medical support, small anatomy, or relatively bad cap or body stress situation for sports. This is the triangle which is successful sometimes, but it's not what we want. The next, please. So we want to have a surgical therapy by athletes with a labrum tear, rotator cuff tear, Bankart lesion, or low dislocations. So this is not a question. They need a surgeon anytime. The next, please. So the latent shear instability, especially dorsal, remains a diagnostic challenge for the physicians, as it often presents a micro and occult instability. And arthroscopy allows the physician to account for all intra-articular lesion and enable definitive classification. I think it's important for the one of colleagues who said, okay, you have to decide intraoperatively sometimes. You can plan the surgery in every time, in the cases. The next, please. So anyway, the athletes with anterior or posterior luxation and therapy resistance, athletes with a single luxation combined with rotator cuff or labrum rupture or bruise, and therapy resistant pain, they need a surgery. And another just with the pain from the technical difficulties or a single injury without bone or tendon or labrum defects, they don't need a surgical therapy. The next, please. But but the pressure still stay. The fulminant expectation of the parents, from serfs, from the girlfriend, boyfriends, from the coaches, from the society, from the TV is still staying. So they have the pressure anyway. Thank you very much for your attention.
Thank you very much, Dr. Kouvakis. So we have some questions for the speakers. I tried to summarize these questions in order. So I have a question for Dr. Hani Sayed. They are asking, do you operate on all patients with anterior dislocation for the first time? So if a patient comes with anterior dislocation, comes to your office, do you advise him to do surgery right away, or do you postpone it after some time doing physiotherapy and follow-up? This is the question.
Sound.
Dr. Hani, speak. We can't hear you.
Sorry. We will put the patient on the age group. What is the age group of the patient? If he is below 20, we will consider first dislocation as a high recurrence rate. So we'll operate him. From 20 to 30, you will discuss with the patient, because we have instance about 70% with recurrent dislocation at this age group, and the activity level is competitive sport, or what is his job, what is his need. So we'll put him on the age group, and we will put, as Dr. Kandil told us about injury severity scores, we will put the patient on this injury severity scores and see what is the benefit of this age group with the surgery. So the issues with the age group.
Okay, I would like to pass this question to the rest of the guest speakers. I want to hear the opinion of Dr. Oliver Verboch. Please, Dr. Oliver.
I follow what just had been said. So the age group is very important, and also the level of sports. I think in a competition athletes, medicine is different than a non-competition athlete, especially if he's professional. Also, the timing in his career or in the season is also important. We have some patients that we will try to keep on track during the season, while we know that we'll have to do surgery after the season, and we just hope they will make it. So this is the discussion that Dr. Kovac already alluded to in a very nice way. So I think it's more like a custom-made or a custom-tailored decision. But in general, in the non-professional or non-competitive athletes, I agree. I think the age group is important, and if you start operating on all of them, you have operated more than half of them too much or too many.
Okay, Dr. Assesi. Dr. Assesi, do you hear me?
Speak.
Dr. Assesi. Okay, Dr. Ahmed Andil, could you give us your opinion, please? Dr. Ahmed?
Yes, I'm not going to add too much to my previous what previous said by my colleagues. Actually, it depends certain criteria. I mean, the age, if he's athlete or not, he or she, the dominance is very important, the level of activity. So all these criteria will make me decide to operate or not to operate. Actually, the most important for me, the age of his or she is very young, dominant hand, professional athlete, and type of sport is like contact or overhead. So I would go for surgery. In other cases, no, I just wait.
Okay, Dr. Assesi, are you back? Okay, Dr. Bassem Friga, is this your opinion?
Well, actually, Hovilas has found in his study, a very good study, that 70% of first-time dislocation will heal and will not really dislocate. So if I have a first-time dislocation, usually I go conservative. Only in two cases, if the patient is an athlete, contact athlete or overhead athlete, and in heavy workers who work overhead, like an electrician, he has always to work like this. So for these patients, I go for surgery. But otherwise, I go conservative. But I tell the patient that there is a 30% possibility that the shoulder will re-dislocate. And most of the patients accept this. Also, in case if the patient is very dependent on the shoulder in his life, I mean, in earning money or in sports, especially professional athletes, they want to be, they calculate that with time. They say, okay, if I don't do the surgery, can I play again? I said, no, you have to also immobilize the shoulder and then you can play after 2 months or 3 months. And then another dislocation, then he also will be out for a long time. And this is for him cost a lot. So most of them, they go for surgery in the first time, dislocation.
Thank you. Dr. Kouvakis, do you want to add anything more?
Yes, I think I just heard all the answers is that almost the same. So I think it's the question of age on the sport level and from the patient too. So I'm coming back all the time to the decision from the patient, because we have our decision very easy. We make our decision very easy and very quick. But the patient, they need to accept all these questions and
tags on the posterior inferior part as well to get the whole hammock and pull it up, so to decrease the capsular volume. And even in some cases we will add a closure of the rotator interval arthroscopically with plication.
We have another question. Do you always do arthrography MRI or do a classic MRI in your cases?
That's a good question. I think that's really depending on the region you work in. Actually, in my country, for instability, we tend to use arthro-CT because it delineates well the labrum and the cartilage. But I do not have any problem with arthro-MRI. And even in the future, I think with the newer machines, we probably have enough on a simple MRI without contrast. Depends on the technology that you have in your country and what you are used to look at.
Very good. We have a last question. They are asking about your preferable surgery in a patient of sport injuries after the second attack of dislocation. He had the first attack and then he developed a second attack. What is your preferred type of surgery? I think you're doing a letter J. Maybe this is the question.
Oh, you mean as a revision? Oh, as a revision.
Yeah.
Or they had already surgery. Yeah, right.
No, they are asking
no
about
surgery.
The second dislocation.
Okay. Well, for me, whether it's the first, second, or the third is probably in surgical-wise, technique-wise, not so different. I look at the type of the patient. I look at what type of sports and what type of injury. But let's assume that it's a second dislocation with a nice soft tissue lesion and a non-engaging heel sacs. I would just do an arthroscopic bankard. If it's more than that, if it's a bone lesion or it's a contact athlete, or there is an off-track heel sacs lesion, I will do a letter shape.
Okay, thank you very much. The question for Dr. Assasi, they are asking about when do you do a posterior inferior capsular shift? I think you mentioned it inside your presentation. Could you give us the
I did, in the presentation, I talk about the anterior capsular shift in case of recurrent anterior shoulder dislocation. I didn't do the posterior capsular shift, but it is for illustration in my presentation only, in case of multi-directional stability. But I didn't do posterior capsular shift in case of anterior recurrent shoulder dislocation.
Okay, maybe I'll pass this question to the audience. If you have like recurrent dislocation shoulder several times, and you have laxity in all directions, multi-directional, what is the preferable type of surgery? We can begin with Dr. Haney. If you have like several recurrence and you have multi-directional instabilities, what is your strategy?
Yes,
How do you
I think I will start first with anterior capsular application and do tightness from anterior and do a full job from anterior and the intraoperative examine. If I still have some posterior laxity, I will add some posterior application for the capsule. But I will, my opinion, I will start all things from anterior. If it's okay, so I don't need to add anything.
Okay, Dr. Oliver, please.
Yeah, I do about the same thing, but I try to determine it preoperatively. So I try to examine the patient well, and I try to determine whether it's an hyperlaxity with a single direction instability or it's really unstable back and forth. And usually it is like that, and so I will do a circumferential capsular. I will repair my most strongest repair will be on the anterior side, but I will add also a posterior capsular.
During your examination under anesthesia, do you have special tests? I mean, if you dislocate in abduction 40 degrees.
Yeah, under anesthesia, I combine without and with anesthesia because I also think it's important that patients alerts to what he feels, and the apprehension sign for me is important. If he's lax posteriorly, but it doesn't hurt him or it doesn't give him any symptoms, it doesn't mean anything to me. So I will compare my findings with and without anesthesia, and I try to also compare bilaterally. But the classical test is the apprehension relocation and the load and shift test.
Dr. Assesi?
Yes, okay.
He answered.
In case of multi-directional stability, after trauma and all cases, multiple dislocations, maybe posterior instability also, due to plastic deformation of the ligaments. In this case, I can do anterior and inferior capsular shift. I prefer capsular shift because I make a flap and I double the capsule heights. And this is very strong. I prefer this method more than anchor method.
Okay, Dr. Andil, please.
Well, actually, this is a very hot topic, multi-directional stability. Yeah, it's a very good question. But for these patients, first of all, I have to take a good history from them because sometimes it's voluntary. So if the patient is doing that by him or herself, I will never, ever touch this patient because whatever you do, it will fail. So first of all, if it's voluntary, I will never, ever touch this patient. I'll send him to do some psychotherapy and physiotherapy because it's a tick. Because each time while he's sitting, studying anything, he will push the shoulder in and out. So whatever you do, it will fail. So history is very important. And then after that, I'll do examination, of course, to see in which direction it's anterior, inferior, and posterior. And it's involuntary. So I will go for surgery. And inside the OR, I will do another examination under anesthesia to detect also the whole direction, anterior, inferior, and posterior, and see the sulcus sign. And then when I go inside, I do plication, start anterior, inferior, and posterior. If I see that it's still unstable, I'll go to do a rotator interval closure. So this is how I deal with the multi-directional instability.
There's no place for lateral in these cases?
No, it's another issue. Multi-directional instability is just something else than anterior shoulder dislocation. So no, we shouldn't do that.
Well, it's Of course, it's a difficult, complicated question, but if you have a multi-directional instability, of course, we are talking about involuntary, as I agree with Dr. Andir in all what he said. So we are talking about involuntary instability. So first of all, in the examination, we have to know the direction. Is it anterior posterior, or is it anterior, if it's anterior inferior, or it is anterior inferior and posterior? It's subluxate in all three directions, or only anterior and inferior? And does it hurt the patient anterior, as Dr. Verboek, as Oliver said, the complaint of the patient, you have to know it, in which direction it is more, and in which movement or which motion he does make him the pain. So we can also demonstrate that. The second thing, inside the surgery under anesthesia, also an examination will be done to see in which direction it is, the head goes mostly. The surgery, of course, what I do, as he said, I do an inferior capsular shift. But in this case, if it is an anterior inferior instability or subluxation or dislocation, I go with the vertical incision inferior as possible to the capsule inferior as possible. So I have a long flap, and when I pull it upwards and I suture it upwards, in most of the cases, this flap will pull the posterior capsule. Also, it will reduce the size of the posterior capsule in most of the cases. And the only difference after that is that the immobilization will not be done in the anatomical position. It will be more in internal rotation. And in case of a multi-directional, both anterior and posterior together, so the patient complaining that the head goes anterior, dislocated, and dislocated posteriorly, involuntary and symptomatic, then I may go even to do an anterior inferior capsular shift combined with a posterior inferior capsular shift. And I did that several times. The only difference is I put then the rotation more in the middle or more in a slightly external rotation, so that I can see in which where is the most hyperlaxity. I put it more in this direction. And for all these patients, it is mandatory to have this position of immobilization for 6 weeks. Not like unidirectional dislocation can take between 3 and 6 weeks, the immobilization in the cast, I mean. But in this patient has to be 6 weeks.
Thank you. Dr. Pavakis?
Yes, I think it's, I had the same experience like Dr. Frega, that the inferior flap, so if you make the inferior flap, is they pull sometimes the posterior capsule in a better position. But I try to come in the surgery with a plan. So I need the pre-operative examination as well as the anesthesia situation and intraoperatively. But I try to go with a clear plan in the surgery. The second thing that I want to say is that for me is the inferior, the anterior inferior capsule dislocation is more important than the posterior, but I do the both of them in the 35% of the cases. but I make first the anterior sutures.
Thank you very much. So we have a question for Dr. Andil. They want to know, is there a difference between open and arthroscopic lethargy? This is the first question. Another question, they want to know exactly your indications. Do you do it in the recurrent cases or in all cases of anterior recurrent anterior dislocation or in revision surgeries?
So the first question, the difference between open and arthroscopic?
Yes.
So yeah, actually it's, I mean, it's the eagerness of each shoulder surgeon to do everything arthroscopically. So that's it. So, I mean, it's challenging. So it's like doing a rotator cuff in open technique and rotator cuff arthroscopically, but I mean.
Is there any evidence-based papers for the results? Is there any other, results are better in open or arthroscopic? Are there any researches?
Yes, there are. And so you have a good idea about that. And the second thing, well, when I do it arthroscopically, I noticed that post-operatively, as regard the rehabilitation, it's faster actually than an open technique. So the patient goes will return to sport faster than open technique. But on the other hand, it's a very challenging surgery, and you should have practiced this type of surgery many, many times, because it needs a very good orientation and surgical skills, arthroscopic skills, I mean. That's the thing. The pros, the cons of that, or disadvantage of arthroscopic lethargy, it's much more expensive than open lethargy, because you're using diathermy, the shaver, all these stuffs, and so it adds to the cost. But open, you just put 2 screws, which doesn't cost anything. But when you do it arthroscopically, of course, it costs a lot. So this as regard the first question. As regard the second question, my indication to lethargy, I just mentioned that in my lecture, my presentation. So all cases that's contraindicated to do Banker's, I will go for lethargy. Athletes, contact sports, presence of severe degree of hyperlaxity, the presence of a bone loss, big bone loss, either in the united side or big heel sacs or bipolar. In revision cases, in all these cases, I will go for lethargy. I don't do arthroscopic Banker. So Bankers, I do it only for non-athlete or just athlete, but in recreational athletes, not professional, in simple athletes, not contact or martial arts, etc., and in the presence of a good labrum, good capsule. So these are my indications to do Banker. Other than that, I will go for lethargy.
Okay, thank you. We have a question for Dr. Bassem Flega. They are asking you to clarify more about intraoperative decision when you do Bankered alone or Bankered with your technique of capsular shift. Twice. So, Dr. Bassem?
Yeah. If I have a Bankert lesion and a capsular redundancy, an enlargement of the size of the capsule together, I first do the Bankert repair. And then after doing that, I examine the stability and examine the capsule again, because maybe through doing Bankert repair, I get a capsular shift. I'm talking about recurrent anterior dislocation. Of course, in dislocation, most of the time I do only Bankert repair. But in recurrent dislocation, you will have a redundancy of the capsule. So first I do a Bankert repair, then I see if the capsule is still redundance, and there is still instability. I examine the shoulder. Then I do an inferior capsular shift. And most of the time in recurrent anterior dislocation, there is a capsular redundancy. I want to also to mention, because Dr. Ahmed Andil mentioned the cost. The techniques for the bank repair and the inferior capsular shift actually is costless. I mean, there is no disposables used, and it is a very great advantage.
Athlete, and he has recurrent anterior shoulder dislocation. What is your preferable surgical technique?
Yes, I think it's. I try to make if the glenoid position is make me possible, I make the Frega technique, because I don't want to have any anchors in a professional athletes. So sometimes is the position is not allow me this technique. Not so. In this case, I put an anchor and I refix the labrum if it's a tear there, and I make a anterior shift room. So, but in this shift I make with a giant needle. So I mean it's I try to make everything without anchors and without sutures.
We have another question for you, Dr. Kovakis. Could you clarify more about the bruises of the glenoid, which you said that you have some athletes with bruises? How can you diagnose them, and what do you do surgically? So we diagnose. I think that the most important diagnostic is for me the MRI. I think the labrum situation I can't see always with ultrasound. So I need a MRI and of course the examinations. And the question of surgery is depend of the sessions, depend of the first from the pain, from the performance. If the athlete can make the trainings every time without pain, if he can compete the championship. So it's a multifactorial answer because it's needed. But the technique is that was the question. I think the technique is I try to make every surgery without any anchors and metal screws. Thank you very much. Now we have a case for discussion, and I'm trying to catch the questions also for the attendees. I will present this case. Okay. This is a patient. He's 23 years old, and he had a dislocation of the shoulder, and he was treated conservatively with a sling for 10 days. Then he returned back to his activities, normal activities. But within 6 years, within 2 years, he had 6 dislocations. So within 2 years, in different positions, in different activities, he had dislocation. In 2 years, 6 dislocations. Then he sought medical advice, and he was advised to do surgery, arthroscopic, Bankert repair. But unfortunately, he had a redislocation. This was his surgery, and this was the dislocation. So I want to open the discussion. First of all, was he treated properly by conservative treatment, by a sling in in the position of a sling, which is maybe an internal rotation of the shoulder for 10 days. So I want to ask, what is your preferable conservative treatment? I'll begin with Dr. Hani, please. Dr. Hani?
Sorry, I need to come back one step because I am start with any patient, I put him on the score to know where is he from the score first, and take a good history from the patient. What is his job? What is his activity? His competitive athlete or his man worker. So I will need to take good history from the patient because, as we mentioned, he's in the age group with a high recurrence rate from 20 to 30. So we need to investigate good. We need to do CT and MRI to see the heel sacs is on track or off track. We need to see the status of the labrum first to decide operative from first dislocation or conservative. Conservative management, as Dr. Bassem mentioned, on the external rotation or internal rotation. Dr. Bassem mentioned we need to put him on the external rotation. I agree with him. Also, it have a lot of debate on the literature, puts the patient on the internal or the external. Some literature mentions that no difference between internal and the external rotation. But I think he need to put on a sling for 2 weeks.
2 weeks, not 10 days.
No, 2 weeks, yeah.
And what is your device for external rotation? Is there a certain device you put the patient in?
Yes, is braces for this position on the external rotation. I have a special braces for this position, yes.
And he continues to this in this position.
And I will start with him physiotherapy and make a close follow-up every 1 month to see what's happened.
Okay, I'll pass the question to Dr. Oliver. How do you treat your patients conservatively in internal rotation or external rotation?
I think there is not enough evidence to do it one or the other way. So I just keep them in a sling for protection for about 10 days to 2 weeks in internal rotation. But if the pain allows to, I even tell them that they can remove it a little bit earlier for daily activities. I think it doesn't really matter. For me, it's most important to have pain relief and get their muscle control back with physiotherapy. I'm not such a big fan of the external rotation things. I must say they're not very well taken by our patients.
Okay, Dr. Assasi?
If I decide I treat this patient conservative, I kept him in sling and external rotation for at least 2 weeks to 3 weeks. And then I start physiotherapy and I follow up him. But in this young age and this group age, I prefer to start from the first one, dislocation by surgery.
Dr. Andil?
Well, for this patient, no role for conservative because, 6 times dislocation, then surgery.
No, I'm asking about the first time. I'm just trying to see what went right, what went wrong. So I'm putting the questions. What did he do wrong? He considered him conservative and placed him in sling for 10 days. So what's your opinion about the conservative treatment? Was it okay or wrong? Or
if the patient is just young and not athlete, and if the patient is for conservative, I just put him in a sling for 4 to 6 weeks.
Put him in a sling for 6 weeks?
4 to 6 weeks, yes. This is the time for soft tissue healing.
And during this period, he does some exercises? Or?
No, nothing. After that, physiotherapy. So this is the time for soft tissue healing. First time dislocation, right? I mean 6 times dislocation or first time dislocation?
No, I'm just asking about the first time.
First time dislocation. After first time dislocation, I put him in a sling for 4 to 6 weeks. This is time for soft tissue healing.
Dr. Bassem, what's your opinion? Dr. Bassem?
Yes, actually, I'm a little bit confused. This is a patient, 23 years old. He had 6 times dislocation.
Yeah, but I'm trying to go back to the first dislocation.
Yes,
What
but
went wrong?
so the question is about the first time dislocation. Is it that correct?
Yes,
Because there is anchor, so he is operated, and so on. So that the question
I'll come back to this later.
Yes, the question is about the first time dislocation. What to do? Well, as I said, it depends on the patient himself. What is he doing? Is he a heavy athlete, the professional athlete? Is he a heavy worker, overhead worker? So first time dislocation for these patients, I will go for surgery. Well, if he say we talk about the conservative treatment, the conservative treatment, I will put him in a complete immobilization for 2 to 3 weeks, and then allow a slight mobilization, but just for eating, writing, and so on. But I also take care that he, for the first 6 weeks, he doesn't do an overhead activity after the complete immobilization for 3 weeks. And I start the isometric stabilization of the internal rotators and elevators after 3 weeks. In the sling, you can do isometric stabilization exercises at home 5 times a day, and every time 5 to 10 minutes, till 6 weeks after the dislocation. Then he start complete physiotherapy.
You put him in a sling in internal rotation or external rotation? Or
no, I put him in internal rotation.
Mm-hmm. Dr. Novakis? Dr. Kovakis?
Yeah. So I think it's about the conservative therapy, and I think I put him in for 4 weeks in a sling in internal rotation. So I don't have any clear evidence with external rotation immobilization. So I think I will put them in the normal internal position for 3 to 4 weeks, and after 4 weeks we have 2 more weeks to slightly mobilization, and after 6 weeks he can go physio and gymnastics.
Mm-hmm. Okay, so the patient went for conservative treatment. Unfortunately, he had recurrent dislocation, one after another. Then he went to a doctor and he did this type of operation, which was arthroscopic Bankert repair. I want to ask the question: Do you see that this was the appropriate type of surgery after 6 times of dislocation in 2 years? So I'll begin with Dr. Hani. What went wrong in this type of, in your opinion, in this type of surgery?
He did surgery after 6 times dislocation.
He did this type of surgery, which was arthroscopic Bankert repair.
After 6 times dislocation. So he need to have MRI to see if any missing pathology inside the MRI.
I mean his decision making after 6 times dislocation that he did.
It's according to the MRI, according to the size of the heel sacs. It's off track or on track. Is there any associated injury, Hagel lesion? I think we need to investigate the MRI and see what's missing on the MRI to make this patient redislocate. I think a matter of number of dislocation, a matter of the soft tissue coverage, the hammock of the inferior part. I think this anchors is inside the joint, and I think he's not shifting the inferior capsular labrum avulsion. So we need to investigate good the MRI before and put the score and see what is this operation is good for this patient, or he need another surgery adding capsular shift or what. So
now you're saying that this surgeon should have a proper investigations, like doing an MRI to detect the lesion, like doing a CT scan to see if there's any deficiency in the glenoid.
Yes.
Before doing his direct surgery, which was Bankert repair.
Yes.
So you advise, if you have a patient with recurrent dislocations, what is your workup? What do you ask to do him as investigations?
Routinely MRI and CT.
Exactly.
Yes.
Okay. You do MRI with arthrography or MRI without arthrography?
It's operator dependent. If I have a technician, I have one very excellent guy. He can do even proton density. I can see everything without arthrogram. So if it's operator dependent, it depends on the technician. If he can do a good MRI for you and the proton density views, you can see everything. I think no need for contrast. But if a new one, you have to do a contrast. So it's operator dependent on MRI.
Dr. Oliver, if you have a patient like this coming here to your office, 6 times dislocation, and you want to do him a workup to decide what type of surgery so that later on he will not have a redislocation, what is your protocol?
Question is from me, Dr. Yasser. Sorry, there is...
For Dr. Oliver?
Dr. Oliver has left, Dr. Yasser. He just sent a message on chat saying that he had to leave.
Okay, Dr. Assasi.
If I have a patient that has 6 dislocations, I will go for request CT and MRI routine to know what my decision. I go for arthroscopic repair or open repair with letter J according to the bone dose of bipolar lesion, and I decision making on CT and MRI is mandatory.
Very good. Dr. Bassem, what are your investigations if a patient comes to you with this 6-time dislocation?
Well, first, the first dislocation happened. Was it a big trauma, or was it just doing a small, an easy thing, say, while sleeping, or there was no really traumas? So if it was a big trauma, I suspected that there's a Bankert lesion. I see that the Sales-Sachs lesion, he doesn't, from the X-ray, it is not very obvious. Then if it was not a big trauma, maybe then a hyperlaxity or hyperredundancy. He is also young. The first time dislocation, he was 21 years old, which is not rare in this age. Then I go, I examine him, of course. I see where is the apprehension, and I examine the laxity by if there is a hyperlaxity. And all these investigation information will give me a hint in which direction I'm going. Then the next step will be an MRI. If it's possible with dye, of course, it will be better. But in most of the cases, the patient refuses to have a dye injection, or it is difficult to have it. So even a good MRI will also give help. So I want to know if there is a bony lesion, which is actually from the X-ray is not obvious. If there is a capsular redundancy or enlargement of the capsule and ligaments, and this can be seen even in a normal MRI without dye, but of course with dye it is much better. I want to see if there is a Bankert lesion, which diagnosed with the MRI. And then I will go for a surgery, pre-planned surgery, that I will go to doing arthroscopy and reconstruct the damage. If there is a Bankert lesion, I will do a Bankert. With 6 times dislocation, there must be a capsular redundancy. So I do the Bankert with an inferior capsular shift in most of these cases. If I do a Bankert alone, the patient may still complain of subluxation symptoms or even there is a high risk of redislocation.
Do you do a CT scan?
Well, if I have a suspicion with an MRI, yes, I will do then a CT scan, but I don't do it routinely. You know, the patient, this is a cost for the patient, and I see in the X-ray if there is only an AP X-ray, AP and axial, and most of the time it will give me the hint about the bony. Plus the MRI about the bony situation. If there's a bony Bankart involved in this, which may be also from the X-ray, I see there can be a bony Bankart, but I cannot. It is not clear.
How did you decide about the size of the Hill-Sachs lesion? Do you have?
Yes. Well, this is also with the MRI. Actually, can you see it very well? The size of the Hill-Sachs lesion, and with experience, you know, I'm doing shoulder surgery now about 40 years, working with shoulder X-rays and so on. So from my experience, I can see that here there is not a large Bankart lesion, and if there is a small one from this X-ray. But of course, the MRI will give us also a good hint about if there is a Hill-Sachs lesion or not, and the size of it. And if it is big, I will go for a CT to have a better evaluation.
Thank you. Dr. Kouvakis, what is your workup for planning surgery in these cases? Dr. Kouvakis? Okay. This patient redislocated his shoulder after the surgery by 6 months. So this is the situation now. MR show redundancy of the capsule, and there is no type of Bankart lesion. It's
upside down. This.
Sorry.
The MRI.
Yeah, sorry. It's my mistake. So I'll go back to the. So what can we do right now? The patient coming to you with redislocation of the shoulder and with these anchors inside the joint. What will you do? Dr. Hani?
Yeah, I think now we have to deal with this patient with a bony procedures like Rotator, because on this MRI we can see that Hill-Sachs is very big, and I think the tissue will not help us to do like a re-revision for this soft tissue. So I think we will go, after investigation, we will go for bony procedures like Rotator, open Rotator, or arthroscopic.
Dr. Assasi?
I need the sagittal oblique cuts to know the type of glenoid, if inverted bear, or I want to know the polylosal glenoid, and the other cuts. We need also to see the MRI, and it may be Hagel lesion. I must know the cause of failure, because if I didn't know the cause of failure, I will fail again. And in this, from this cuts, it is a large bony defect, Hill-Sachs, and I also, in this case, I will go for letter J.
Okay, Dr. Ahmed Andil.
Well, actually, in such a case, I wouldn't ask for MRI. I would ask for a CT, just because actually in the previous surgery, he has metal anchors. I really need to know if, especially the inferior anchor, if it's inside the bone or if it's protruded. So to have a good idea about that, I would ask for a CT, and then I would definitely do a letter J.
Will you do it arthroscopically? You're going to remove the anchors arthroscopically and do the surgery arthroscopically, or is it?
I can do it both ways, either arthroscopically or open.
Mm-hmm. Okay, Dr. Kouvakis, Dr. Bassem Fliega, please.
Well, I have to have more information. I mean, we have to an MRI and so on. But I will do I deal actually a lot with these cases, and my strategy is to see if there is if the anchors are inside the bone or outside, and this also can help me through CT before that. To decide if I have to remove the anchors or not, or if the anchor is floating, is looking out from the bone. Anyway, if I will remove an anchor if it is hurting, and then I will see if the Bankert lesion, I will repair it also. If there is a Bankert lesion transosseously, and I will do a capsular shift. I will not go for a lateral J only if there is damage to the glenoid, if there is a glenoid fracture and the fractured bone is absorbed and it's not existing, and there is a defect in the glenoid, which also can be pre-operatively assessed with the CT. In this case, I will go for, say, lateral J or Bristow. And but otherwise, I don't go for lateral J if the glenoid is in its size. I will just repair the damaged soft tissue, and then we have a rehabilitation customized on this case. But in most of the cases, the patient go very well with that, unless there's a damage to the cartilage with causing so the anchor itself is actually, if it is loose, that you can expect damage to the joint.
Thank you very much. Dr. Kouvakis, how are you going to manage this case? I think he left. Okay. I just want to remind you that the coming webinar will be in February, 5th of February, under the title, Is there a need for subacromial decompression and when to do it? I invite you all to join our society, the EGSSA, and to register for this webinar.
One thing I just want to say that we want to thank Mr. Mina Munir from EVA company, who supported us very much in this webinar and also webinars before. And we want to invite him now to speak because he wants to also make a presentation on products of his company and what his company can help us and help the patient.
Thank you very much, Dr. Bassem, and thank you very much, Dr. Yasser, for moderating this webinar. And thank you very much for all the chairman and panelists, and as well as for the attendees to offer EVA Pharma as the honor to be with you this night. And I would like indeed to congratulate EGSSA for this very prestigious webinars, not only the first one, it is the 5th, and we are going to be with you on the upcoming webinars, inshallah. But as Dr. Bassem said, I would have some minutes, not too long, to share with you some highlights about one of our products in EVA Pharma. So please let me share my screen. I hope it is clear now to all of you. So I'm going to talk about one of our product in Eva Pharma, which is Cytacid. I do believe that many of you know it very well for treatment of neuropathy, but today I'm going to highlight on some important points about Cytacid, its mechanism of action, and its safety profile. As we are going to talk about Cytacid, the main topic will be peripheral neuropathy and what happened to the nerve when it is maybe injured to transfer from the normal nerve, as you see, to the abnormal status by cascade of events. Can we call it a pathophysiology of neuropathy? But according to the International Association for the Study of Pain, peripheral neuropathy treatment or neuropathic pain treatment focus on 3 points, which are treating the underlying cause if possible. Maybe the patient cannot undergo some surgical operation, or maybe in cases of diabetes and metabolic disorders, it is a long-lasting disease. The other point is treating symptoms, which is the main driver for the patient to come to you doctors to ask about relieving this pain. I believe that is very annoying pain. And also treating the nerve fiber damage, which is a very important, and this is a point that I'm going to focus with you this night. And as we all believe that nerve injury occur at a certain point whenever there is a compression or injury at a certain point in the nerve, and then cascade of events occurs till it might pass through sheath loss, disconnection, and maybe degeneration at the end of the case, where this point there is complete loss of sensation for the patients. But it is very important to agree with you on a specific point regarding the pathophysiology of peripheral neuropathy. And this is the physiology in which the healthy state is affected to transfer to the unhealthy state, as you see, a very weak nerve, demyelinated, without nerve supply, blood supply. It is begins with mechanical or chemical irritation, as you know, whatever the cause. Maybe it is metabolic, it is nerve injury, compression, canal stenosis, many cases, and I believe that you on daily basis see some many cases of these. This results in compromised intraneural circulation, affecting the circulation to the nerve with reduced exoplasmic flow and consequently supranuclear edema, inflammation occur in the nerve that results in at the end intraneural fibrosis. Whenever you can interact or interfere with the patient, either mechanically or pharmacologically, according to the case severity, patient profile, it is very important to stop this progression, to go further, and maybe to conserve the nerve from being completely lost. Also, other points regarding the pathophysiology, whenever peripheral nerve compression occur and axonal injury might happen, this results in inflammation, inflammatory storm occur, increasing tumor necrotic factor, interleukin-1 macrophage, and Schwann cell inflammation. This results in, as I said, tumor necrotic factor alpha, especially receptor excitation, and formation of pro-inflammatory cytokines and other inflammatory mediators. But by the way, I want to focus on a point that will be very important regarding the mechanism of action of Cytacid, is that whenever tumor necrotic factor alpha is inhibited by selecting antibody therapy, this results in preventing intraneural edema, prevented reduction of nerve conduction velocity, and improve abnormal pain. And this is very important as an approach for the pharmacological treatment of neuropathy. Also, I might share with you that increased reactive oxygen species production cause consequent reduction of nitric oxide bioavailability, which is an important, maybe I can say important molecule in maintaining the diameter for the blood flow and maintaining the reduced nerve blood flow in the vagus nervura. Also, trauma induced, as I said before, interleukin 1 beta, interleukin 1, and human necrotic factor, as well as caspase-3, which is a programmatic apoptosis that might occur for the nerve. As I said, caspase-3 play an important role in apoptosis mediated by caspase-related protein cleft. So, to conclude the pathophysiology of neuropathy, in two directions, tissue damage, as you see, passing through peripheral nerve injury, upregulation of B55 receptor, increased production of human necrotic factor, and as well cytokines, interleukin 1, 6, and apoptosis of the neuron. On the other hand, I have a problem in the blood flow to the nerve where there is peripheral nerve injury, compression, ischemia, edema as well, caspase-3 activation, and at the end, apoptosis. All these occur in the nerve on over time interval, maybe differ from the cause and from patient to another. So in order to conclude pathophysiology of entrapment in neuropathy nerve compression syndrome, let us deal on that. It is in three directions: microvascular changes regarding blood flow problems, injury and demyelination, where the myelin sheath is very important for normal nerve signal transmission, and inflammation and oxidative stress that occur due to this compression. So what is the aim? I think you agree with me. Whenever you are thinking of a treatment, pharmacological treatment, especially for neuropathy, you need cure, to find a curative treatment for this case in order to stop the pain, or even to give a treatment to stop the pain. But at the end, if you will be able to cure the cause, consequently, it will be reduced the pain, and at the end, no pain will be found. And maybe you need to have a drug that can cure the cause, and other drug or the same drug maybe to stop this pain. Here comes cytosine with its powerful combined actions for treatment of neuropathy, as I will review with you now. But before talking about cytosine and its mechanism of action, I would like to share with you that EVA Pharma is celebrating this year with 20-year cytosine, real-life experience and the clinical experience for treatment of neuropathy. EVA Pharma has launched cytosine by its name, alpha-lipoic acid or thioctic acid, 20 years ago. And we are very proud with your confidence and your support regarding cytosine being your drug of choice in many cases of neuropathy. As I said, it has been launched since 2001 by EVA Pharma and is registered in many countries worldwide, maybe 5 or 4 continents: Africa, Asia, North America, and Europe. And by the way, it has been approved for treatment of diabetic neuropathy alpha-lipoic acid since, do you imagine, 1959. Maybe over, what about 60 years? 60 years of using this molecule with a high confidence of its effects. So what is cytosine? Cytosine, the active constituent is alpha-lipoic acid or thioctic acid that is sensitized by the liver and acts as coenzyme in Krebs cycle. It is already found in the body. And this is very important to reflect on its safety profile. Also, alpha-lipoic acid has amphiphilic character. It is both water-soluble and fat-soluble. And this is an important character differentiating alpha-lipoic acid from other molecules. Also, alpha-lipoic acid acts by both its reduced and oxidized form. The mechanism of action of cytosine might be summarized in its vasoprotective effect, neuroprotective effect, and antioxidant effect. Being an antioxidant, it has important advantage over other antioxidants because it is amphiphilic. It itself is a powerful antioxidant and free radical and metal curator scavenger, and act as antioxidant and dealing with free radicals. Even dihydroalcoholic acid, which is the other form of alpha-lipoic acid, is not destroyed, as I said, but can be regenerated from lipoic acid by re-reduction. Also, it is said on alpha lipoic acid as the universal antioxidant. Yes, the universal antioxidant, because it has a very potent antioxidant effect and directly scavenging reactive oxygen species. Also, it's best to regenerate other antioxidants like vitamin E, vitamin C, and intracellular glutathione. Here is collection of its antioxidant power effect. Also, by reducing free radicals, the mechanism of action of cytosine, and apoptotic and neuroprotective effect of alpha lipoic acid on what? On spinal cord ischemic reperfusion injury. This has been approved and shown by histologically and biochemical papers and trials. Also, alpha lipoic acid was found to promote peripheral nerve regeneration. It's very important, I believe, for patients who are suffering from later stage of peripheral injury. Also, alpha lipoic acid in cytosine was found to reduce tissue level of caspase-3 and interleukin-1 beta, as shown in serum level of C-reactive protein. Also, alpha lipoic acid significantly prevent nerve injury, progression of the case, as I said before, induced function loss, and increase nerve regeneration. It is very important for crushed induced degeneration in both axon and myelin sheaths. Also, it inhibits activation. It acts as anti-inflammatory because it inhibits activation of nuclear factor kappa B, human necrotin factor, interleukin-1, and interleukin-6. Also, it has effect on pain because it modulates the T-type cell calcium channel, so it reduces the pain. Also, it increases the nerve growth factor, which is a stimulating factor for promoting nerve fiber damage, and improve blood flow to the vasonervorum by restore a normal level of nitric oxide mediated vasodilation. By this, and by fitting the mechanism of actions of cytosine on the pathophysiology of entrapment neuropathy or nerve compression, we will find that in microvascular changes, vasoprotective effect of alpha lipoic acid is here. Injury and demyelination, neuroprotective and remyelination is found. Also for inflammation and oxidative stress, the anti-inflammatory and antioxidant effect for cytosine will be here. A lot of papers and the trials were talking about the role of cytosine in different cases of nerve compression. For example, and not for numbering, this is for sciatica, an observational multi-center study on chronic sciatic pain. It has been collected from 44 Italian centers. And in this paper, the neuropathic mechanism of sciatic pain was oxidative stress and the inflammatory pathway. This results in sensitization, spine sensitization, and the chronic neuropathic pain. For alpha lipoic acid, this paper mentioned clearly that alpha lipoic acid as an antioxidant is the first choice, as you see, treatment for chronic neuropathic pain, and because of its proven effectiveness compared to placebo. Also, alpha lipoic acid has protective effect on the nerve fibers, acting on nerve inflammation and the progression of nerve damage. It is very important that this trial also mentioned that alpha lipoic acid reduced analgesic medication. You imagine, by improving the underlying pathophysiology, we can reduce the need for analgesic, and this will be very will have very positive effect for the patient. Also for radiculopathy, the same is here. Alpha lipoic acid improved cases of neuropathy by improving blood flow of the vasonervorum mediated by antioxidant alpha lipoic acid. And at the last, for carpal tunnel syndrome, alpha lipoic acid reduces oxidative stress by increase the activity of different molecules inside the body. Also, alpha lipoic acid where an ischemic reperfusion process triggers the disease, so it improves the blood supply. And this trial has recommended that alpha lipoic acid administration 1 month before and 2 months after decompression, nerve decompression for carpal tunnel, improves the clinical and neurophysiology outcome and decreases also pillar pain. Many papers and trials, maybe we can discuss it on upcoming webinars about neck pain, sciatic pain, and carpal tunnel, and in general peripheral nerve. Also, it's very important to highlight that cytosine is recommended by different guidelines as pathogenetic treatment for diabetic neuropathy, including the ADA, American Diabetes Association, British or German Diabetes Association, Egyptian Diabetes Association, Toronto Expert Panel Canadian Association, and Polish Diabetes Association guidelines. All these guidelines mention cytosine as only alpha-lipoic acid, which is recommended as pathogenetic treatment, differentiated from other molecules that might be for symptomatic treatment. So, for indications, you can use cytosine for diabetic neuropathy, carpal tunnel syndrome, lumbar radiculopathy, cervical, sciatica, and low back pain with sciatica. Also, regarding safety, I would like to ensure that cytosine is not effective just for a neuropathy, but is as well safe. Up to, we don't need those adjustments for elderly patient, renal impaired patient, liver function impaired patient, cardiac hypertensive, and for sure diabetic patient. And this, I'm sure that it gives you confidence to prescribe cytosine for many patients. Regarding the dose, in general, alpha-lipoic acid or cytosine is recommended as a dose, therapeutic dose ranging between 600 and 1800 milligram per day. Recommended to start with high dose for severe cases and to titrate the dose for milder cases. Just an important point that for cytosine or alpha-lipoic acid specific molecule to be taken on the stomach, this is for the molecule itself for maximum absorption. So for mild and moderate cases, we can start with 1200 milligram per day, and for severe cases, 1800 milligram per day, and in general, a maintenance dose for 600 milligram, as long as the patient is responding and there is improvement in the case and in Europe. I do believe that these words is the first words that the patient asks you at the beginning when he comes to you to visit you in the clinic. Doctor, I'm tired of this nerve ending pain. So by your wise to treat this patient, you think how to treat underlying cause and relieve his disease pain in. Eva Pharma also, besides cytosine, has other products, Sympatix, which is Droxtine, and Conventine, which is gabapentin, as a neuropathic painkillers, and Genofil, which is triple combination of glucosamine sulfate, chondroitin sulfate, and methyl sulfonyl methane, MSM, for osteoarthritis. And thank you very much for your patience, for letting us to be with you this time. Thank you, Dr. Bassem and Dr. Yusuf.
Thank you very much. Thank you very much, Dr. Munir, Mina Munir. And by this presentation, we ended our webinar, and we hope to see you in the next coming webinar next month. Thank you very much.
Thank you, doctors, and please stay safe.
Thank you.